All right, so my topic is tibial atherectomy devices. Next slide. And I do not have any relevant disclosures to this. Next. So tibial atherectomy, as we know, the data about anything, any of atherectomy devices is kind of sparse. And these two papers, which are somewhat recent in 2019 and 2022, they were sort of suggesting that the first one, the XPDA, was basically a real-world registry data. It was published in 2019 by Dr. Khaliq's group. It basically compared the use of atherectomy, and it showed that atherectomy use had somewhat less limb-related interventions in the following 1 year, especially in the patients who had CLI, in-stent restenosis, and heavy calcification, and presence of diffuse disease and CTOs. And this other paper, which is also interesting, is published like in basically in April of 2022 in the Journal of EVT. So basically showed that the use of basically showed that, obviously, as we know, associated adverse outcomes with atherectomy. However, they show that these outcomes are less so with tibial interventions, which is kind of interesting because they also go on to say that there's less associated dissections in tibials, but more stent use. So, which is kind of interesting. But regardless, a very high technical success. And that's the best we can say, that, these are somewhat safe and lead to better procedural success. Next. As we know, the tibial vessels have all these problems which make them difficult to treat and which lead to more ISR in them and frequent interventions needed. So the vessels are small, the lesions are long, there are multiple occlusions, more so than stenosis, and there's severe calcification. Next. These are the gamut of devices we have available. Next. Okay, so again, just belaboring the point here, why we need atherectomy is because there's because of calcium, there's more recoil, and atherectomy, like we showed, is associated with less dissections, and again, with different plaque morphologies, soft as well as associated thrombus, we may need different types of atherectomy devices. Next. So CLI orbital atherectomy. So it's actually my preferred choice in the below the knee space, and I'm sure we can later, quiz the panelists about their preferred choices. So I usually use the 125 microburr, and I have found it to be very, it's a very ease of use. I know that it can also be, it's 4 French compatible, so some of us who do primary pedal access, they also find it equally useful. Next slide. So this was their below the knee study, which essentially showed that the balloons expanded at lesser pressure, and there was associated less bailout stenting. Next. I think we can skip this. It's just a demonstration of. Next slide. This is just one of my cases. Basically opened a PT with the following technique, used a 125 microburr, and essentially did a long nanocross balloon, 30200. Next slide. So these are some tips and tricks which I guess all of us know. Essentially slow runs, slow advancement of this device, long runs, avoiding long runs and using antispasmodics between runs, keeping the ACT high. The dictum is that the tibials behave like coronaries, so essentially treat them like coronaries in terms of ACT. Next. And again, directional atherectomy. So it's a device which we use for concentric as well as eccentric plaque, and it's highly effective and safe in the below the knee space. Next. This is these are the types of devices we can use. TurboHawk, the SXC and SSL can be used in below the knee space, and in Hawk 1, the 6 French S can be used in the below the knee space. Next. This is their data from Definite LE. They of the 750 patients they treated, a very small number of patients were actually infrapopliteal, but nonetheless, this is what we have, and it showed essentially, good primary patency at 12 months, which is not that dissimilar from above the knee device use. Next. And now going to laser, and now that we have more than one type of laser, in addition to the Turbo Elite, we have Dabra and Arun devices as well. Next. So essentially, with about lasers, vaporizing technology, it uses two mechanisms of sonic wave and UV light. And next, please. And these are this is data regarding use of laser in below the knee space. In the first study, which was basically of about 400 patients or so, out of which about 40% were below the knee patients, it showed that there was an overall 85% procedural success and a significant 93% limb salvage at 6 months. Again, the second study also showed, basically was done in laser infrapopliteal and popliteal stenosis. This was more like a retrospective review, and it showed that that basically laser use versus PTA, there was significant, demonstrably 5% higher improvement in lesion severity score. Next. And this is one of the other laser below the knee studies, which is basically the SELA study. And next, I'm always baffled by how the number of patients in our trials are so less than in the coordinate trials. So this is an 80-patient study, but nonetheless, this is the data we have. And essentially, 47 of them went to PTA and 47 of them had laser. Next. And at 3 years, this study showed, there was a demonstrable clinical improvement, and clinical improvement, I guess, was defined by primary patency. And there was also a significant amputation-free survival and 3-year freedom from TLR. Next. So this is actually a patient of Dr. Matthews. I borrowed the slide from him. He's again opening a PT using laser and a DES, which is frequently nowadays used. Next. Again, a bit about technique, same thing, good flushes, and we talked about the sizing being an important principle. So my rough guide is to use 66% or 2/3 of the vessel size. And again, atherectomy basically done to also it's one of the approved atherectomies for thrombus and soft plaque as well. Next, and ISR as we saw. A bit about the Phoenix device. So essentially now Phoenix is one of those devices in addition to Rotarex and Jetstream, which not only cuts, it has an anterior cutter, it also has a passive clearing mechanism, and it has a passive suction, and therefore it can be used in lesion morphologies where we think thrombus is concomitant issue. And the other good thing about this is that it has a good crossing profile and is most of the times 6 French compatible, except the very big devices which we use in SFA and CFA. Next. And this was their single-arm multi-center trial, which basically was 105 patients. And again, the co-primary endpoints were again acute debulking and less than 50% residual stenosis, which is how they define technical success. Next. And Phoenix was the only atherectomy used. And as you can see that at 6 months, they had pretty decent TLRs and target vessel revascularization, so 88 and 86% respectively. Next. This is basically from the same study, good demonstrable acute technical success, and it was safe at 30 days with not that many complications related to the device use, and kind of a little bit higher unplanned toe amputations, but CLI patients, so who knows. Next. Again, now this is one of the other cutting and aspirating devices, thrombectomy and atherectomy devices, Jetstream, which essentially can be used in the below the knee space as well. And they have a 185 millimeter device, which they use in below the knee space. I actually personally have never used Jetstream in below the knee, and I know that it's a Boston Scientific device. So sometimes what we would do is we could use their rotational atherectomy They have a specific rotational atherectomy, rota PV, which is longer shaft length. It's 135 shaft length, and because of which it can be used in up and over circumstances. In case you're not able to do that, and you're not able to have access to that device, a regular rota can also be used, either antegrade or pedal axis. Next. And this is one of the Jetstream cases. It's courtesy of Boston Scientific, this slide, essentially showing that a good outcome with just 3 passes of Jetstream. Next. And this is their data published by Dr. Zeller's group in 2019. Again, 172 patients were treated, and out of them 9%, so not very many, but still not an insignificant number of patients, were treated for infrapopliteal interventions. Next. And essentially showing the same thing, which we see with these atherectomy devices again and again, is that they lead to acute technical success. But as we have said, that we haven't seen that much hard data on them. But again, this does show that there's some there's better clinical driven TLR at 6 and 12 months. But this is not compared to any comparator. It was a single arm study. Next. So I guess any discussion is incomplete now without the introduction of shockwave lithotripsy, which we have been using in the below-the-knee space now as well. So basically, it's their S4 device. Next. Next. Yeah. So essentially, this is their data from the Disrupt BTK trial, and it was primarily designed for below-the-knee patients. Again, you see not that many patients, 20 patients, and it shows good safety outcomes, no dissections, no embolizations or perforations, and pretty good efficacy in terms of residual stenosis of less than, I guess they took 30%, so 26%. And a good acute luminal gain is, again, not as compared to any comparators. It's a single arm study. And again, a follow-up of 30 days, they showed 100% freedom from TLR. Next. Oh, I just had one more slide. It's fine. I was just going to talk about a slide about next. Yeah. So these are the sizes. Next. And again, Serenata is one of the new balloons which has the serrations and has these cutting jags. I have personally not used it, but I know Sinai has, and other colleagues here have significant experience with it in below-the-knee space, and it seems to be doing a good job at atherectomy. These are the sizes that are available. I'll put them up for you. And next. Again, basically just the rundown of the same. I'm not going to belabor this, what I already talked about. Next. Thank you very much. That was all.